Good. So I was given the title of Evolution of PCSK9 Inhibitors, Pipedream, or Evidence-Based Reality, and thank goodness for this meeting, because we can add a lot more of evidence-based reality. So I've divided this up into what I would consider the evidence, and dividing this into 5. So firstly, does PCSK9 reduce LDL? And do we have evidence for that? Do they reduce cardiovascular disease? Is there any additional cardiovascular benefit from achieving very low LDL levels of less than 25 with PCSK9 inhibitors? Are they safe? And are there any safety concerns with very low LDL levels? So in terms of lowering LDL, we know from phase 1 trials with 2 fully human monoclonal antibodies, they've shown that there's a maximal and stable 60% reduction in LDL once all PCSK9 has been bound. And this occurs at 70 to 75 milligrams of a high affinity monoclonal antibody like evolocumab or alirocumab. Higher doses do not achieve additional LDL reduction. Unlike statins, which are limited purely by toxicity, these drugs are not limited by toxicity, they're limited by efficacy. And once you get to 75 milligrams, you reduce LDL about 60% for 1 week. You double the dose to 140, 150, you can suppress LDL stably for 2 weeks. And if you triple the 2-week dose to 420, 450, you can suppress it for 4 weeks. You get the same LDL reduction. It's additive, not synergistic, whether you add it to diet, low dose, high dose statin, or statin plus ezetimibe. We know that FH and non-FH patients respond the same, and the response is independent of the LDL receptor. We know that there is a response in homozygotes, but it's half of what we see in non-homozygote patients. We know that statin-adverse patients tolerate these drugs, and we also know that in addition to LDL, we get a pretty robust reduction in Lp(a). Let's cover the first point here. So here, hard to see, but this was the free PCSK9 in the alirocumab pooled phase 1 studies. And if you have a look at the first red bar here, 75 milligrams, and you can see that 75 milligrams up to 300 milligrams gives you the identical PCSK9 suppression or free PCSK9 levels at the end of 1 week. The second bar here is at 14 days, and you can see that PCSK9 is now increasing. But if you look at the 150 milligram, you can see it's still suppressed, and for 300 milligrams, you can see that that continues suppression. In fact, you can go to even higher doses. So this is the first trials we published with alirocumab, 5 years this month, so we've come a long way. And you can see that you can go up to almost a gram intravenously, and you don't get any additional LDL reduction, but you get out for nearly 60 days. Now, monoclonal antibodies, you can only get about 150 milligrams in 1 ml. So if you go above 150, more than 2 weeks, you have to give either multiple 1 ml injections or you need a device. What about the increase from 140 to 420? And here's a fairly robust trial. You can see that 140 milligrams every 2 weeks in this study in 110 patients versus 420 gave you identical 60% reduction at the same time point, week 12. And here, on top of diet alone, this is a Descartes study where patients were treated according to ATP3, and you can see that whether you're on diet, atorva 80 or 10, the pink bars here are placebo corrected, that there's 60 plus or minus a couple of percent in terms of difference. This is from Gauss-3, and to show you the tolerability of PCSK9 versus ezetimibe in patients who had proven statin adverse symptoms on a rechallenge with atorva, but not on placebo. You can see that while about 1 in 5 patients still complained of some muscle toxic or pain, there was only 1 patient, 0.7% of patients who discontinued the evolocumab versus about 7% who discontinued ezetimibe. In terms of heterozygous FH patients, where we know we get an overall reduction of 60%, the same as non-FH, it doesn't matter whether you have LDL receptor negative function, defective, or unclassified, you get this boring same 60%. So the underlying receptor for a heterozygote doesn't make any difference as long as you got one good receptor. For homozygotes, we get this 31% reduction, which doesn't sound like a lot, but in fact, because their LDLs are so high, you get the largest absolute reduction of LDL that we see in any of the trials, and it is related to the underlying LDL receptor. The more residual LDL receptor function you have, the better your response, which actually is pretty common sense. And here we know that at the doses approved, we get a 25 to 30% decrease in Lp(a). So let's turn now to, do we reduce cardiovascular disease? So what evidence do we have? I know that Paul dislikes these studies, but we had some early promising, and this probably didn't do us a lot of good because we raised expectations. So in this small trial of OSLA, which was a exploratory analysis, we saw a hazard ratio of 0.47, and in the same issue of NEJM, the Odyssey long term, which was a post hoc analysis, we saw the same reduction of roughly 50%. The numbers were very small. You're talking about 56 to 61 patients in each of these studies. We also know from Glagov that we see more regression. Steve Nissen reports more regression than he's seen in any other trial, with an LDL that got down to a mean of around about 36 in this trial. And then we have the data from Fourier, presented just a couple of days ago, where in terms of the primary endpoint, we see a significant reduction in events, and that we start seeing separation as early as 6 months, and at 1 year, we see about a 10% reduction or a little less, and this increases over time, as we know, even with all statins and lipid-lowering agents, the longer you go, the more benefit you get. And for hard endpoints, the secondary endpoints, again, it was programmed to be ended, the trial was programmed to end based on a hazard ratio of 0.85, and that's what determines when a trial ends, and 1,630 events minimum. And you can see here that, again, over 3 years, you get an increasing effect on cardiovascular events, highly significant. And if we look at the events that really cause us problems, death is pretty cheap for a healthcare payer, other than the fact that you lose the premium. The fact that stroke, myocardial infarction, and revascularization were highly significantly reduced, and those really are the high costs and burden of cardiovascular disease. Let's turn now to achieving very low LDL levels. Is there any benefit? Many of my colleagues have told me that this will plateau at 50. 50 milligrams is the sweet spot, and that you won't get any additional cardiovascular benefit. Well, we have a study published by Kaushre, which looked at the 10 phase 3 alirocumab trials in high-risk patients, and what you see here is a continuing straight line, that there's as much benefit as going from a mean of 75 to a mean of 50 as there is by going from a mean of 50 to a mean of 25. Now, don't be fooled. This is not 25. This, as they point out, is a mean of 25. And you all know that if you have a mean of 25, half the patients, roughly, are going to be below 25, between 0 and 25. So we've seen a straight line, and it's the same millimole reduction gives you a 24% decrease in events. In addition, from Glagov getting down to 20 milligrams per deciliter, we see a straight line with as much regression occurring from 50 to 20 as we see from 50 to 70. In addition, the analysis based on achieved LDL from Fourier, you can see that the patients who achieved the lowest LDL had the lowest event rate, and as Mark Sabatine summarized, lower LDL is better. Let's turn now to safety, because that becomes an issue. And if we look at the overall safety events, you can see no difference, specifically no difference in cataracts, no difference in neurocognitive events in this trial. No difference in transaminases. And these drugs are unique in that FDA does not require any post-treatment safety monitoring, as we still have for statins, which is pretty unique for a new class of agents. So what about getting to very low LDL levels? And again, this goes back a long time, but can LDL cholesterol be too low in terms of safety? Now, if you look at the bottom, this is from 2005, and it comes from a trial called the Prove It trial. And the idea of the Prove It trial, and this was not funded by the manufacturers of atorvastatin, but by the manufacturers of pravastatin, who were telling physicians that you don't need to get more than 35% reduction in LDL, and if you get an LDL below 125, it may not be good for you. So what we have is déjà vu all over again. We have concerns about hemorrhagic stroke and cognitive impairment in terms of this. So if we look at Prove It, you can see here that if we look at hemorrhagic stroke, while there was hemorrhagic stroke, it was all in those patients with LDLs that were in the higher ranges with no signal, even at the lower range. What about now going forward 10 years to improve it? And here we have a lot of patients. We have nearly 1,000 patients treated for an average of 7 years with LDLs below 30. And again, people raised the same effect, neurocognitive and hemorrhagic stroke. And if you look at these patients with the lowest LDL levels, you can see that they had the lowest rate of impairment and hemorrhagic stroke. So let's go forward to look at signals that we may have seen. Here's the OSLA trial, where we showed you the cardiovascular benefits, and you can see what looks like a signal of increased impairment, 0.3 to 0.9. But if you look at those patients with less than 25, this is the lowest level of cognitive impairment, so no signal of an increase. And the same thing with Odyssey long-term. If you look at placebo versus the overall population, it is again the same 2.5-time increase, but in those patients with consecutive LDLs below 25, no increase in the signal. So we know from the Ebbinghaus cognitive trial that assessing this on a prospective basis by 3 methods, there was no difference between placebo and treatment. And in fact, when they did a post hoc analysis of less than 25, 25 to 40, and greater than 40, there was no difference according to achieved LDL levels. What about hemorrhagic stroke? And this is the global safety database presented to FDA for alirocumab, and if you look at those patients less than 25 or less than 15, there was no signal of increased hemorrhagic stroke. And if we look again at FOURIER, remember that the median was 30, but 25% of these patients had LDLs below 20, 42% below 25. And if we look at hemorrhagic stroke, there's no increase in hemorrhagic stroke in the entire study. There's no increase in cataracts. And then data presented by Paul, or published by Paul recently, helps get this cataract question even further clarified, in that when he looked at patients below 25, they had the lowest rate of cataracts. And in fact, the patients whose LDL didn't go below 25 had higher rates at 1.3. Overall, no different. So I think in conclusion, patients achieving very low LDL levels, less than 25 and even less than 15, do not show an increased in clinical or laboratory side effects compared with those with higher LDLs or control groups in properly randomized trials. The cardiovascular event rate and IVUS data shows that there's continual additional cardiovascular benefit, which is the greatest health risk for these patients when you get to even lower LDL levels. I think based on the current evidence, the real safety concern is leaving your patients undertreated and not achieving LDL levels as low as you can. And then I think safety and benefit data for very low LDL based on increased LDL clearance. And I think that it's important to understand mechanism does matter. If you increase LDL receptor activity via statin, ezetimibe, or PCSK9 inhibition, plus the unreliability of Friedwald formula when LDL drops below 50, I think we should eliminate the lower level for LDL cholesterol, just as we have eliminated the lower limit for CRP. So finally, in terms of the title I was asked to address, I think this is no pipe dream. 5 years ago was the first data published on a PCSK9 inhibitor in humans, and today we have definite evidence-based reality. Thank you.